Okay, now CNS stimulant. This is a small topic. Psychomotor stimulants and hallucinogens are the two groups of drugs that act primarily to stimulate the CNS. Now you can see the drugs: amphetamine, armodafinil, atomoxetine, caffeine, cocaine, dexmethylphenidate, dextroamphetamine, dexamphetamine, methamphetamine, methylphenidate. These are all derivatives. Modafinil, nicotine, theophylline, varenicline. These are the CNS stimulants. Now psychomotor stimulants. Methylxanthines. Methylxanthines include theophylline, theobromine, caffeine. Caffeine is widely consumed in the world, and coffees, chocolate, candies, drinks, and cocoa. Mechanism of action: several have been proposed. Action of methylxanthine, including translocation of extracellular calcium, increasing CMP and CGMP, caused by inhibition of phosphodiesterase and blockade of adenosine receptors. Now in CNS, what does caffeine do? 1 to 2 cups of coffee will cause decrease in fatigue, increased mental alertness as a result of stimulating the cortex and other areas of the brain. CVS high dose will have positive inotropic and chronotropic effects on the heart. It is a mild diuretic because these stimulate secretion of gastric acid. Peptic ulcer should avoid foods and beverages containing methylxanthines. Therapeutic uses: it relaxes the smooth muscles and bronchioles. These are largely replaced by other agents. These are absorbed orally and generally by CYP1A2 pathway. It is metabolized. Adverse action: insomnia, anxiety, and agitation. Now nicotine. Nicotine is an active ingredient in tobacco. Mechanism of action: it causes ganglionic stimulation by depolarization, and high doses causes ganglionic blockade. Action: CNS. It is readily absorbed by blood-brain barrier. Cigarette smoking and administration of low doses of nicotine produces some degree of euphoria and arousal. It improves attention, learning, problem solving, and reaction time. The lower doses of nicotine causes arousal and relaxation. High doses of nicotine causes. Okay, now peripheral effects. The peripheral effects of nicotine are complex. Stimulation of sympathetic ganglia as well as of the adrenal medulla increases BP and heart rate. It is pharmacokinetics: highly lipid soluble, absorptions readily by all mucosal membranes. Adverse effects: irritability and tremors. Withdrawal syndrome is caused by nicotine because it is an addictive substance. Irritability, anxiety, restlessness, difficult in concentration, headaches, insomnia, appetite is affected. Now the transdermal patch of nicotine has been shown to help smokers. Now other forms of nicotine replacement are used, but bupropion, which is an antidepressant, is the first drug of choice for smoking cessation. Now potential for withdrawal: insomnia, headache, irritability, and potential for addiction by nicotine. Now varenicline. Varenicline is a partial agonist and a neuronal nicotinic acetylcholine receptor in CNS. Next is cocaine. Cocaine is widely available and highly addictive drug. Because of its abuse potential, cocaine is classified as a Schedule 2 drug. Potential for addiction: cocaine, amphetamine. Amphetamine is a sympathetic amine that shows neurologic and clinical effects similar to those of cocaine. Dextroamphetamine, methamphetamine, these are all derivatives of amphetamine. Mechanism of action: effects are on CNS and PNS. Both depend upon an elevation of the level of catecholamine neurotransmitters in the synaptic spaces. Achieve this effect by releasing intracellular stores of catecholamines and also inhibit MAO and a weak reuptake transport inhibitor. High levels of catecholamine are present in synaptic spaces. Now you can see the mechanism of action here. The neurotransmitters they go and bind and produce response. When amphetamine is present, it stimulates the CNS. It means these neurotransmitters release will be enhanced and the response will also be enhanced. Actions in CNS are complex. The CNS stimulant in sympathetic nervous system. Therapeutic uses include psychological and physiological dependence. Now in this ADHD, some children are hyperkinetic and lack of inability to involve in any activity for longer than few minutes. So these may alleviate the behavioral problems associated with this syndrome. Now necrolepsy. Necrolepsy is a relatively rare sleep disorder that is characterized by uncontrolled bouts of sleepiness during day. Appetite suppression. Pharmacokinetics is completely absorbed by GI. Adverse effect: dependence, tolerance, drug-seeking behavior. CNS effect: insomnia, irritability, weakness, dizziness, tremor, hyperactive reflexes. Vertigo, hypertension, insomnia, confusion, potential for addiction, nausea, diarrhea. Cardiovascular effect: palpitation, cardiac arrhythmias, hypertension, and general pain. GI effect: nausea, vomiting, abdominal cramps. Contraindication is with hypertension, CVS, hyperthyroidism, glaucoma, and abuse. Now methylphenidate. It also has CNS stimulant property to those of amphetamine, and it is a Schedule 2 drug used for ADHD. It is a weak dopamine. It produces weak dopamine signals. Therapeutic uses are just for ADHD. It is also effective for necrolepsy. Methylphenidate. Dexmethylphenidate is not indicated for necrolepsy, so you have to remember this, that this meta is not. Now pharmacokinetics, these are readily orally absorbed. Adverse effects: anorexia, insomnia, nervousness, and fever. And it will inhibit the metabolism of warfarin, phenytoin, phenobarbital, primidone, and TCAs.